Welcome everyone, and it's been an amazing symposium so far, and I'm glad to launch the second day. We're going to be focused on data this morning and the importance of data. And Kate's going to advance the slides, so you can go ahead. And so what I was tasked with doing this morning was to really just talk about why data collection is important for programs. And I say that because, collecting data uses resources, and sometimes people wonder, like, why shouldn't we just put all of our resources into, another operation, for example? So another child has surgery. Why should we put resources into data collection? And so really, there's three reasons. One is that it's really, certainly in my mind and in the minds of many, of an essential part of being a high quality program. Another reason, and we'll talk a little bit more about why, another reason is because this is how you guide quality improvement work and actually make programs better over time. And then the last reason is that it allows transparency of how a program is doing for stakeholders. And stakeholders can be parents or patients, it can be governments, it can be payers, it can be NGOs. Having data allows transparency and a lot of better communication, as Blanca talked about yesterday, about how programs are doing. Next slide. So I was the Chief Safety and Quality Officer. I ran the quality program for our hospital for over a decade. And while I was doing that, I created this framework about the essential parts of having a high quality safety and quality program. And we put them on the points of the star, but basically what they were, first of all, governance and accountability. The leaders of the program have to own the way that program's doing. The second one is evidence-based review, which is really using data to know how you're doing. The third one is improvement initiatives, which is using that data to get better over time. The fourth was event review, which is looking into things when things go wrong. They don't go the way you expected. And the last one is culture or normative behavior, right? Making the right thing to do the normal thing to do where you work. And two of these, which is the point, evidence-based review and improvement initiatives require data. Next slide. Back. Okay, so what is evidence-based review? What does that mean? It means that you're going to use data to assess performance. And ideally, you're going to have data that compares how you're doing to other organizations like yours, because that's how you're going to be able to understand how you're doing. And it may require a little bit more complicated statistics to adjust for different things about different people's patients that they're operating on. And so when you understand all that, you understand that participating in registries is a very useful way to accomplish that. Next slide. And so there's some really big registries out there. One of the most famous of all is the Society for Thoracic Surgeons database. It's here in the United States. It's very much similar to the one that the Europeans use. And this is just their website, which really explains, what it's about. And nationally recognized quality and performance measures for cardiac programs and cardiac surgical programs in the U.S. Next slide. The problem is that in a lot of low resource settings, a big registry with the United States, comparing it to very wealthy programs with lots of resources, feels a little bit unfair. It doesn't feel right. It feels like the patients are different, the resources are different, and the like. So in order to start to address that, we put a registry in our IQIC, International Quality Improvement Collaborative for Congenital Heart Disease, which is all focused on improving care in low and middle income countries. And this is really a quality improvement activity, but it includes a registry. And the overall goal of IQIC is to just make care better so that more children get operations and survive operations worldwide. Next slide, Kate. And we have a number of global partners in this work, and I will say that Global Arch is a major partner of IQIC. Next slide. Yeah. Mhm. And so this is just a snapshot of the programs that were participating in IQIC in 2023. And as you can see, there's quite a number of programs really distributed in a lot of places with lower resources. And we have a surgical registry as well as a catheterization registry that we launched a few years ago that's growing as well. And so when we started all this, there was very little information or high quality information about what was going on in some of the lower resource settings, but we now have a lot of data. We have over 160,000 cases in the registry, just in the surgical registry, as of a short while ago. And next slide. And what we use that data for is to help let programs guide their quality improvement and do that evidence-based review. Every year they get a benchmarking report. Our reports went out a few weeks ago. And they're able to see the kind of cases they're doing compared to other people. They're able to see how their outcomes are, and they're able to see those risk-adjusted outcomes. You know, when you take into account differences in different places, how are they doing? Next slide. And then this is just a slide to show that other point on the star about quality improvement. So many of the IQIC programs are using that data to guide quality improvement. We also participate here in a registry run by the American College of Cardiology, which is a network in the United States devoted to improving care. And this is actually a slide of the quality improvement in my own department on one of the measures there that was about genetic testing. And it shows all the quality improvement too of all the different things we did in the department to do better on this measure. Next slide. And so just to say, these collecting data to know how you're doing compared to others like you, and also to guide your own quality improvement are really an essential part, one of the core parts of being a high quality program. And I just want to say that it doesn't just have to be clinical outcomes. This is just a slide from ICHOM, the International Consortium for Health Outcome Measurements, that created a multi-dimensional patient-reported outcome focused a group of measures about how patients are doing, how patients are doing who have congenital heart disease across the lifespan. And many groups contributed to developing this measurement set. And I would like to see these patient-reported outcomes used way more globally than they are now. And the last reason to collect data is that data is the engine behind advocacy. Stories are the engine too, but a really important engine if you want to turn the key to help ministers to unlock resources is to have data. And so that's why collecting data, that's why Children's Heartlink named their series, a blueprint series about the problem of inequity in congenital heart care around the world, the case for the invisible child. That's why Global Arch has invisibility in its new initiative. And that's why the call to action to reduce the global burden of pediatric and congenital heart disease includes data as a formative component. So those are all the reasons and rationale about why data is important. And I think that's my last slide, Kate. So I will turn it over to Dominique, who I think will be guiding more discussion.
Thank you, Dr. Jenkins. We'll now move into our panel. It's my pleasure to introduce Dr. Dominique Vervoet. Dr. Vervoet is a PhD candidate and Bonnier Scholar at the Institute of Health Policy and Management and Evaluation and at the Division of Cardiac Surgery at the University of Toronto. He's also a founding president of the Global Cardiac Surgery Initiative. Dr. Vervoet, I'll turn to you to introduce the panel and the esteemed panelists.
Great. Thank you so much, Kate. And thank you so much, Dr. Jenkins, for your wonderful talk, which really sets the stage for our discussion today and kind of alludes to the fact that we aren't just talking about data collection today, but also about acting upon those data. So really taking into account evidence-based review of those data, introducing quality improvement initiatives, and really trying to make sure that we iteratively improve those processes over time. We have a fantastic panel today. The panel is titled Data Collection and Sharing, Creating Access, Not Barriers. And for that, we will have three panelists who I'll ask to briefly introduce themselves. So we have Dr. Jenkins from Boston Children's Hospital, who we've just heard from during this fantastic talk. We have Dr. Liesel Zulke from the University of Cape Town and Red Cross Hospital in South Africa. And we have Lola Fernandez from Cardias AC from Mexico, representing kind of the patient family advocacy voice in this panel as well. So we've heard from Dr. Jenkins, so I assume that everybody has had a chance to listen to her fantastic talk so far. So perhaps Dr. Zulke, would you like to introduce yourself briefly?
Yes, thank you very much. Thank you, Dominique, and thank you to Global Arch for the opportunity to be on this panel. And thank you to Kathy for those really important points to setting us all off. I'm a pediatric cardiologist based in Cape Town, South Africa. I work at the South African Medical Research Council, and I've been involved in the science and the data around both congenital and specifically rheumatic heart disease for the last 2 decades or so, and really valued Kathy's insights into the importance of data. So thank you very much for having me on the panel.
Great. Thank you so much, Dr. Zulke, for being here. Lola Fernandez, are you here as well?
Hi, I'm Lola. I'm from Cardias in Mexico. I'm here representing an ONG. So that from this point of view, Kathy, I want to thank you in front of everybody for creating IQIC. It's an amazing gift, a donation that most ONGs would not be able to pay. And it's the only way we have gotten better. No, like the medical team, and even from the ONG point of view, we have been able to find so many things that we can change just because we can see the numbers. So really, I would like to stress this, that it's an amazing gift that you have given us. Thank you.
Thank you.
Great. Thank you so much, all. So I'd love to kind of kick off the panel here. And I also want to encourage everybody who is in the audience to kind of share your questions in the group chat, in the Zoom chat here. So we'll be monitoring that as well to ask any of those questions as well to our panelists. But just to start off, we've kind of have people here who are leaders on different sides of the story in terms of both grassroots advocacy and patient family representation itself, all the way to research and clinical care. And so I'd love to kind of get your perspective as to how data collection, whether it is at your institution or in your NGO or within your respective health systems, has currently played a role in improving care for your patients with CHD and or RHD. And perhaps if you have a specific example where some of that data sharing with patients or even public reporting of those data have actually led to improved outcomes in the current care delivery. So whoever feels most inclined to jump in first, feel free to do so. But it'd be great to kind of hear your perspectives on this question.
Dominic,
Yes,
can I share?
of course.
Well, as I was telling you, besides being able, we operate in 2 centers, a public and a private one, like Blanca was telling you in yesterday's meeting. And we have been able, with the data collection, to make to have better outcomes in the survival rate, because we can see in real time what's going on, and the doctors can assess it. But this has also helped us. So we have a different survival rate in the public and the private hospital. And this is interesting, and we can see it in the data. And we have been able to, working on the private, because we have better controls, control systems, we have been able to make the correct protocols in order to make better the survival rate at the public hospital as well. So this is an example of how it's worked for the doctors, but I mean, maybe Kathy has much better examples of the medical area. Also, as an ONG, we do continuous education. We invest in that. And it has been interesting to see where the children are coming from. Like now we're using the database for other areas, and we're seeing where the children are coming from and which doctors are in that area for the counter reference of these patients. So we can also give them continuous education. So for us, it's been interesting to see, you know, how they go back, where they go back to, and how we can help the doctors at those areas. Because once we we let the kids go, they go back to their states, and they have to be, you know, in the hands of other doctors. They might not come back to Mexico City. So this is a way for us to use the data, you know, so, and we're finding other ways. So as I was saying, we're very grateful.
Great. Thank you for sharing. Dr. Zolko or Dr. Jenkins?
Yeah, Dominique, thanks very much. And thank you to Lola for those comments as well. Very interesting. I'm going to change the area here a little bit. We're also involved in IQIC, and it's been a really important tool that we've used, also incorporating them into our M&M meetings, for example, and instituting clinical changes, different clinics, and in particular identifying patients that are at risk, our neonates or those that are lost to follow-up. But I'm actually going to respond to a question that Amy put into the chat, which speaks in a way to your question, which is how do you share information about the projects or the areas in the data that has highlighted either a gap or a facilitator with patients? And this takes us back to the Remedy study, which was a rheumatic heart disease register, which shared, looked at data across 2 years and identified gaps in the evidence-based interventions, specific gaps. For example, taking a warfarin and making sure that your INR was in the normal range. And the way we did that was actually present those data to the participants in the study before we presented it on the scientific stage. And what we were able to see based on that was a change in the bilateral relationship between patient and medical professionals. So instead of a patient saying, thank you, this is my INR, they were now able to say, you haven't booked an INR for the last 2 months, and my last INR was out of range. And that actually sort of really changed that relationship, made for a positive engagement. And what we started to see was actually really improved outcomes. When we did a study 2 years later, one of the things with the study that was profound was the time in therapeutic range, which was probably higher than in many of the studies around warfarin in high-income countries. So this data can actually lead to a change in outcomes, but more importantly, a shared relationship with the participants. And I thought that would be a good example. Thanks. Back to you.
Yeah, and I mean, I'll just add, this is in no way a discussion that is, you know, a discussion specific to low resource settings. It's as important, all the things we're talking about in the top programs in the world. And just as one example, in our hospital that happened recently, had to do with radiation safety in the catheterization laboratory. And we have a big project, actually, it was started here by Lisa Bergerson in the United States, and the IQIC cath registry is very aligned with it. The US one is called C3PO. And we've been tracking our radiation exposure during catheterization to try to improve it. It was a big focus of that project. And we moved into a new building a couple of years ago. And so all the cath labs moved over. And when they got their first reports, the radiation looked higher. And they sort of ignored it, you know, the first time. And the second time said, well, we can't, like, what happened? And they had the engineers go check, and something hadn't been set up exactly right with the equipment. It had been set up differently in the new building, and they fixed it. And had we not ourselves set up that registry and had those benchmarkings, we might not have caught it, you know, for a while. And so there's just always examples like that where, you know, healthcare is very complicated, and things can get in control and then out of control, you know, and so the data is really what helps you. In the IQIC space, one of the best examples was one of the very top programs in Brazil were just sure they were doing really well. Everywhere way they could tell, they were doing great. And when they got their reports from IQAC, that wasn't quite the case. And so they did exactly the right thing. They really looked into it very carefully. And they thought they ended up deciding they needed to do a lot of quality improvement work around the cardiopulmonary bypass team. They just didn't have the right skills and education and equipment. So, that's what happened. And we ended up setting up a whole course, to try to let others, improve around that. In terms of Amy's question about sharing with patients and families, I think there's a lot of goodwill around that. There's been a lot of call for that. The concerns that people have is that will parents and patients, be able to interpret the information in context. And so I think most people think it always has to be done, with that context around it.
Great. Thank you so much, Dr. Jenkins and Dr. Zolka, for sharing. And I think kind of one other example that alludes to that as well is kind of the push towards public reporting of outcomes in a variety of countries. So for example, I know in the US and in the UK, there's a big push towards public reporting of outcomes, 30-day outcomes, 1-year outcomes of cardiac surgery, congenital heart surgery in specific. And for example, in the UK, kind of a bit of a change in practice has come from the late 1990s, where initially there was a bit of a concern about outcomes across a couple of centers, where then after a certain introspection as to why the outcomes were worse in certain centers compared to others, there was a bigger push towards public reporting and research into these differential outcomes across centers, where nowadays in the UK, but also in the US, people from outside of those institutions also have a better sense as to what the outcomes are across the country. And that for the public might lead to, it's a bit of a double-edged sword, as you mentioned. On the one hand, it creates trust because people really know what's going on in different institutions. But we also have to make sure that it doesn't get misinterpreted as to more complex procedures, obviously having slightly poorer outcomes compared to easier procedures, and that doesn't create kind of a false narrative amongst the media or amongst the public as well. So it's a bit of a balance that needs to be sought. I want to kind of, I was going to jump into the next question from the public, but I see that it's been addressed in the chat itself. So I'll jump to a next question in the meantime, and something that might be quite relevant for a lot of the audience here, as well as patient and family organizations themselves, being kind of the topic of quality of life. So usually, or at least historically, a lot of the research that has been ongoing, a lot of the databases have mostly kind of focused on hard clinical endpoints. So survival of procedures and long-term survival, need for reinterventions, and so forth and so forth. But I think everybody here obviously recognizes that quality of life is just as important to kind of better understand and track over a lifetime as well. So my question for you, whether it's in terms of your respective institutions or databases, or with your NGO, do you have a sense of what types of quality of life data are currently being collected as part of your work or as part of your work for colleagues? And this could be either for patients with congenital heart disease or rheumatic heart disease. And then also how these quality of life data might currently or in the future be used to better improve patient-tailored care and improve long-term outcomes as well as it relates to care decisions.
Well, I'll just go back, Dominique, to the slide that I showed, a short introduction to a nice complex topic, the ICHOM congenital heart disease measure set. That was heavily influenced by the outcomes that matter to patients and families in what was selected to be in the set. And it's really beautiful. It includes, multidimensional health-related quality of life, being able to participate, in activities, freedom from comorbidities like arrhythmia, for example. It goes way beyond the traditional, so-called clinical heart outcome measures. It's been a really heavy lift. to get it implemented. The other side to your point about balance of the comprehensiveness of it is it also it's hard, to implement it within the process of healthcare. We're actually doing it now in my department. We're still not fully launched, but I'm really proud of that. But I think it's incredibly important. And I think that really is the long-term goal, is to have the longest period of time with the highest quality of life as our real measures. And we can align our research and our clinical care around that if we had the measures.
Yeah, I can only but agree with Kathy that this is such a critical area. But I'm afraid what I have to say is not as positive, in that we don't collect patient related outcomes. We don't collect that even in a private practice, knee replacement surgery, which is something that happens perhaps almost invariably in the UK or the US. So in most low and middle income countries, and I'm certainly not speaking for everyone, this is still a long way off. Even some of the data points, the hard outcomes, are not collected on a routine basis. And so it's very encouraging to have templates that can be adapted and used in countries. We've been involved in a few quality of life outcomes, which has really been a research tool and used within research programs, which is sometimes how things start. So there is a little bit of a start and a little bit of an understanding of the importance of those data. But I'm afraid it's certainly not something that is routinely collected in probably most of my country, around almost most of the issues that we see. Thanks.
Yeah, one of the problems is that collecting this kind of data, even the basic data, isn't necessarily considered to be part of routine healthcare. And that's the mind frame we're trying to shift, right? That if it was considered essential, it's the same as having a nurse in the ICU. It's the same as having a pharmacist in your pharmacy. It's not considered that way. It's considered extra. And so it's and the more data it is, and the more complicated and the more people you need and computer systems you need to collect it and analyze it, even more so. So there's always this trade-off between the resources to collect the data and all the data that we wish and think would be valuable. That's an everyday conversation in hospitals.
Thank you both for sharing that. That's very valuable to know that, on the one hand, there's kind of that recognition, but on the other hand, there's still not really kind of a consensus to properly embed this in terms of both data collection and improving care decisions. Lola, from Carias's perspective, has there been kind of any discussion in terms of embedding these quality of life measures in terms of the current operations, as well as then also from kind of the organizational perspective, how might kind of the recognition of patient-centered care and quality of life outcomes influence some of the direction that several NGOs, such as the one of yourself, are currently taking within the space?
Well, I mean, this is basically done by the doctors. We're not taking much into account, the same as Lisa was saying, the patient outcome afterwards. No, we sometimes we lose contact with the patients, and it's not something that they see. So but as an ONG, I think somebody was asking what an NGO was. I'm sorry. And as an NGO, we are doing something. We're giving an example to other programs in the country, since they were not collecting data. Now we know another important one is collating data through IQIC. So it's better for competition. Is that answering your question, or am I? Yes.
Yes, absolutely.
Okay, and then we are most of the data we're collecting is, so the doctors are looking at it constantly, week by week, and we have been able to solve very important issues immediately. That is for center patient, as you were saying. So it's improving the lives of the patients immediately and helping them come out of the ICU in the best way possible.
Great, fantastic. Thank you for sharing that. I'm cognizant of the time because I know this is a very stimulating discussions and there have been a couple of questions in the chat as well. But just in the interest of time before the next session starts, I'd love for each of the panelists just very briefly to kind of reflect on kind of a final question, and that's more related to patient and family organizations themselves and how you individually collaborate with patient and family organizations for data collection, as well as what role that the audience here, so patient and family organizations, can play in helping to collect data and improving data collection mechanisms, and then obviously the consequent quality improvement initiatives that might result from that. So maybe in the same order, Dr. Jenkins, would you like to start?
Oh, sure. Yeah. Well, I think that the patient and family organizations that I'm connected to in the United States, I'm mostly connected to through something called the Congenital Heart Public Health Consortium that everyone's at the table so we can communicate more freely. They've been advocates already, for this. And I think what the parent and patient family organizations can do is, continually, remind the healthcare organizations or the big registries that this is something that people want, and that the things that people are worried about, like misinterpretation of information and the like, that they'll help with that. And they also can encourage people, to participate, if they're asked for permission, to collect data, that they help people understand why it's so important, with proper protections of individual privacy and all of that in place.
Great. Thank you so much, Dr. Jenkins. Dr. Zolke?
Yeah, no, I completely concur with what Kathy has said and why some of the collaborations with patient and family organizations are important. But in addition, perhaps one of the other issues that we haven't raised so far is about hypothesis generating. So this also gives us an opportunity for patient and family groups, when they see a particular variable, particular gap in the clinical care or in policy, to identify that as something that they would like to have investigated or researched. And again, bringing the previous example, the INR example, one of the things that came out of the patient and family group once we represented or presented those data was that we actually need an alternative. Can you start looking for one? And that led to a study in itself. So I think it's important to highlight how critical that engagement is, how that actually speaks to this concept that research is the origin should lie in a team approach, and that certainly is one. And so that would be one other thing that I would say we should consider. Thanks.
Great. Thank you so much, Dr. Zolke. Lola?
Yes. As a family and patient organization, it is very important to know the outcomes of the programs in every country in order to make, right decisions and promote quality improvement measures. All organizations should advocate for outcome information and transparency. So the way we're doing it right now is by using it, by exercising the use of this database. And as I was saying, we should go to the government and ask for them to do it. At the moment, it might not be, something that they would agree on, but we're giving the example, and now other institutions are copying this. So this is a way to promote transparency, like thinking outside the box on how we could do it. Also, we have talked to many other family organizations because they've asked how Cardias did it, and it was difficult but not impossible, and I think it can be replicated anywhere. So if anybody would like to contact us, to see which steps we took in order to file for to be part of IQIC, it would be great. for them
And
to feel.
I'll just add that another thing, I think Cardias is a fantastic example of those. Lola's not even telling the whole story there, where they supported the individuals, even in the government program, to bridge that gap for resources, and really talked about why it was important, but then also were able to convince some of the large organizations that know how to handle data to help them make the data more interpretable, which is really nice. So, but if you are working in an area where it's just going to be impossible with the resources in the healthcare system to prioritize this, an NGO that can raise money, or find philanthropy, or convince, foundations, for example, to just bridge that gap so people have, the resources to put the data in the computer, and analyze it. That would be a really important first step, because once people see the data and how valuable it is, that's how, it'll get resourced better over time.
Yes, thank you. It's great that you said this, Kathy, because what Cardias did is that we hired a person, a specialist. We have the information of what kind of person this should be. And he's doing all the data, but we were paying for for his salary and whatever he needed. And now there's 5 or 6 people working in this team. And as you were saying, now it's obvious how important, and like the breakthrough we've made thanks to the data, and those salaries are not necessarily so expensive, so it's not so difficult to start with a small team if you can fundraise for that. And I think that's one of the first steps in understanding that maybe NGOs should not only be paying for surgeries or for medical materials. Maybe we should also be, a way to advocate is to support these areas, like data collection.
I've always, I've literally worked, people think we have tons of resources, but I've always worked in low budgets too. And there's what I call like the really expensive way to collect data, and then the much more practical way to collect data. And part one of that is what data you collect. People are always interested in many things. So just the amount of data that people want or think they need can just expand. You have to be really mindful of the most important ones. And then, you don't want your cardiac surgeon, putting data in the computer. It's like your most expensive resource. You want to get really well-trained people who learn a little bit about data and congenital heart surgery, and let them do most of the work. They find it really rewarding, and just let them check with the surgeon, for example, did I get it right? And that strategy is just way more effective. And so we've always tried to build IQIC in our registries around that model.
Great. Well, thank you all so much for sharing all of these excellent thoughts. And Kate has also shared links to the different projects that you've mentioned in the chat. So for the audience who's interested in learning more about that, feel free to click on those as well after the sessions. And I guess with this, I'll try and wrap up the session itself. We've heard from 3 leaders in the field, different aspects or different stakeholders in kind of this care discussion and data collection discussion. And I think one key point, or maybe 2 key points that kind of came out of this from my perspective has been, one, that it's a collaborative effort. It's not a single stakeholder issue, but it's really, it should be, as Dr. Zilke mentioned, a team-based approach to really ensure that everybody who is directly or indirectly kind of interacting with data or influenced by these data is also a stakeholder and a part of these discussions and of these processes. And then the second part, and as Lola mentioned as well, is that data is really critical for advocacy. And advocacy, I've heard it from different people, has also been kind of positioned as evidence-based messaging. And I think the messaging that we put out as a collaborative all kind of stems from the data that we collect, either individually as NGOs or researchers, but also collectively as a community. So with this, I'll try and wrap up the session. I'll hand it back over to Kate, and I'm looking forward to the discussions and the rest of the day as well.